And I'm going to say, and in 5, and if you can start, please. And in
Good morning, my colleagues. My name is Jacek Zachwieja. I am pediatrician from Poznań, Poland. And today I would like to share with our experiences regarding renal replacement therapy in pediatric COVID-19 patients. This is my disclosure. And first of all, I would like to greet you from Poznań, Poland. Poznań Medical University is one of the most important medical universities in Poland, with almost 10,000 students. And we perform dialysis in Poznań from 1958, and we observe continuous development of different techniques. And this is our department looks today. So as an introduction, short introduction of my topic, I would like to tell you that our last data shows that almost 250 million people suffer from COVID-19 infection, and we have more than 5 million deaths at the moment. The high rate of infection is related to easy transmission, of course, and as we know, the person-to-person spread is the main mode of SARS-CoV-2 transmission. However, infection may also occur if a person's hands are contaminated by secretion or touching contaminated surfaces, and then by touching eye, nose, or mouth. We know that SARS-CoV-2 can be also transmitted over longer distances through the airborne route. And we also know that COVID-19 has been detected in non-respiratory specimens, including stool, blood, ocular secretion, and semen. But the role of these sites in transmission is unclear. What is very important from, let's say, dialysis point of view, because we have close contact with the blood-borne transmission appears to be very low. If we are talking about children, it's important to tell some words about potential vertical transmission, but the extent of vertical transmission remains still unclear. There are only few well-documented cases of probable vertical transmission, which are responsible for approximately 2% of maternal infections. And in general, pregnancy does not appear to increase susceptibility to acquiring SARS-CoV-2 infection. How about newborns outcome? As we know and as we see, over 95% of newborns of positive mothers are in relatively good conditions at birth. Most are asymptomatic, and some newborns or infected mothers have developed symptoms of mild infection. However, neonatal morbidity is related mainly to preterm birth and to adverse uterine environments resulting from critical maternal COVID-19. As we all know, not only pulmonary system is involved in SARS-CoV-2 infection, we may have different symptoms and signs from the heart, from the kidneys, as I will tell you some more in a second, but we may have also clinical symptoms related to liver involvement, to gastrointestinal tract problems, and central nervous system involvement. How about kidney? COVID-19 infection may present as mild proteinuria, mild erythrocyturia. The presence of tubular cast is described in those patients, and sometimes tubal epithelial cell cast can be present. Sometimes the whole, let's say, Fanconi syndrome is also described in those patients with COVID-19. How about patients with chronic kidney disease? This is very special group of patients because these patients may have different comorbidity, may suffer from diabetes, hypertension, and they are dialyzed in the dialysis centers, so it may facilitate the spreading of the infection. That's why the first advice from our point of view is to use a special protective equipment. This is essential, this is obvious. However, I have to tell about it some words. At the moment, we have, for example, two children who are dialyzed with COVID-19, and we use gloves. We use, of course, face masks. We also use face shields because we know that personal glasses and contact lenses are not considered adequate eye protection, and we use isolation gowns. So the basic principle of our dialysis department is to protect ourselves. First of all, we have to protect ourselves, then you can dialyze your patients. So this is very important. And we have implemented several, let's say, rules in our hospital, in our dialysis center. First of all, we have implemented policies that permit ill health personnel to stay home. It's important because we have, let's say, a lack of personnel all the time in our dialysis department. We have to identify patients with early symptoms of respiratory infection before they enter dialysis department. We have instructed our patients to call ahead to report potential fever and respiratory symptoms, so the dialysis center is prepared for their arrival. Or we triage them to a more appropriate settings, for example, acute care hospital. Patients are informed to inform staff of fever and respiratory symptoms immediately upon arrival at the dialysis center. They should put a mask, of course, and carry this face mask all the time. And we have provided our patients with instruction regarding hand hygiene, respiratory hygiene, cough etiquette, which is important, and of course, use of face covering. There are special issues related to COVID-19 treatment in dialysis patients. First problem is related to erythropoiesis stimulating agents, because as we all know, COVID-19 infection may lead to higher risk of thrombosis. So during last month, we have decreased the doses of erythropoiesis stimulating agents, and we keep our patients and hemoglobin of our patient in the range between 10 to 11 grams per deciliter only. And we, of course, vaccinate all our patients, adolescents mainly, because smaller children are still waiting for the approval of vaccination. But we, let's say, vaccinate all these patients with at least 2 doses at the moment. Some of them are receiving third dose of vaccine. Some words about COVID-19 infection and acute kidney injury. There are many data about acute kidney injury in COVID patients, and in one of very important meta-analysis of approximately 13,000 mostly hospitalized patients, as you see, the average incidence of acute kidney injury was 17%. However, there was a broad range from 0.5 to 80% of patients who developed acute kidney injury. In adult population, approximately 5% of patients required renal replacement therapy, In pediatric population, this number is lower, between 1 or 2% of patients require renal replacement therapy. It's important that the incidence seems to vary by geographic location and proportion of critically ill patients, including in each study. And there are some data showing that the rate of ECI is declining over the duration of the pandemic. Some words about pathogenesis of acute kidney injury in COVID patients. As you see, there are some direct effects of the virus, and there are some indirect effects of the disease, and both of these effects may have negative influence on kidney function. A very important issue is dehydration, which is commonly seen in those patients, which is secondary to decreased fluid intake, vomiting, diarrhea, overuse of diuretics, because our anesthesiologists want to keep, let's say, the lungs dry. Yes, so they use diuretics, and sometimes dehydration is an important factor in the development of acute kidney injury. Of course, what is well known, cytokine storm syndrome and AKI, so acute kidney injury, may occur due to renal inflammation, increased vascular permeability, third space fluid loss, intra-abdominal hypertension, and hypovolemia. There are also different interactions between organs. For example, aggressive ventilation and hemodynamic instability are associated with altered kidney function as a component of so-called organ crosstalk. We know that there are some local effects of the virus, because the virus can attack proximal tubules, not only proximal tubules, but mainly proximal tubules. And of course, use of different nephrotoxic drugs, including antiviral drugs, may lead to acute kidney injury. Pathogenesis of acute kidney injury in COVID patients and the high risk of acute kidney injury is related to high number of ACE2 receptors found within kidneys and TMPRSS receptors found within kidneys. And that's why we can demonstrate viruses within not only lungs, but also within kidneys, within glomeruli, within tubules. But not all patients are positive for SARS-CoV-2 within kidneys. And as you see from this presentation, the risk of acute kidney injury is related to the presence of viruses within kidneys. Yes, if the patients are positive for SARS-CoV-2 within kidneys, they have higher risk for acute kidney injury development. And those patients who are positive within kidneys have a lower probability of survival. So this is important factor which will influence the further course of the disease. From histopathological point of view, the typical abnormality is acute tubular necrosis. However, sometimes collapsing form of focal segmental glomerulosclerosis can be seen, and in many cases there are thrombi found within glomeruli. And depending on the degree of acute tubular necrosis, we can observe different stages of acute kidney injury. How about renal replacement therapy in our patients, in our small babies? The general rule is that the indications for renal replacement therapy for acute kidney injury remain the same regardless of the COVID-19 status of any given patients. We have some practical, let's say, issues which should be remembered. We are trying to keep our patients close to intensive care units. So our dialysis department are closely related and localized with intensive care unit, of course, when it is possible. If our patient is in negative pressure isolation room, then one hemodialysis nurse will need to be dedicated to the care of that patient in one-to-one nurse-to-patient ratio. Yes, patients with suspected or confirmed COVID-19 who are not in critically ill status, but who require renal replacement therapy should be dialyzed in the isolation room rather than being transported to the inpatient dialysis unit. And we prefer to start and to perform continuous method of renal replacement therapy in our children with ECI in the course of acute COVID-19 infection. The machines, continuous renal replacement therapy machines, can be placed both inside the room or outside the room using extended tubing. Of course, placing the machine outside the room will minimize the need for repeated entry to troubleshoot the end to the manage of the machine. So therefore, it will reduce the wastage of personal protective equipment. Extended tubing, however, is a scarce resource, and use of extended tubings requires additional tubing connections and increases the likelihood of tubing will be disconnected. And what is very important in our pediatric center, that those extended tubings would increase the volume of the blood which is outside the body, which is a very important issue in pediatric patient. Extended tubing also decreases the sensitivity of pressure alarms to detect disconnection of the venous lines and potentially increases the risk of clotting due to the longer tubing length. And one important issue is related to the number of machines which are available in every hospital, and if renal replacement therapy capacity at the hospital is overwhelmed, those continuous renal replacement therapy can be used to deliver prolonged intermittent treatment with higher flow rates, of course, so we can treat more patients. Very important issue related to renal replacement therapy in our patients is risk of thrombosis, as I mentioned, because those patients have higher risk of thrombosis, which is well known, let's say, observation, and of course those patients should receive anticoagulation, because sometimes we can perform dialysis without any anticoagulation, but these patients should receive any anticoagulation, and we usually use at the moment low molecular weight heparin. We can use also unfractionated heparin with higher doses. And we have to remember that regional citrate anticoagulation appears to be less effective among COVID-19 patients. How about the timing of starting dialysis? According to KDIGO guidelines, timing of renal replacement initiation, vascular access, and modality of renal replacement therapy should be based on patient needs, local expertise, and the availability of staff and equipment. So there are no special, let's say, issue regarding the special method of the treatment. Some words about peritoneal dialysis, because we have patients on peritoneal dialysis and COVID-19, but Please remember that patients with acute kidney injury and COVID-19 who are treated with peritoneal dialysis have similar rates of all-cause mortality, kidney function recovery, and infectious complications compared with patients treated with other modalities. Peritoneal dialysis can, of course, increase intra-abdominal pressure, which is well known, and it can interfere theoretically with respiratory mechanics. But in practice, in our everyday practice, performing peritoneal dialysis in a mechanically ventilated patient is usually feasible and safe. And we prefer automated peritoneal dialysis if it is available, but in our center, all our patients have cyclers, and in most or almost all patients are treated with automated peritoneal dialysis. And data, please remember the data suggesting peritoneal dialysis effluent is infectious are lacking, so it is relatively safe procedure. Last but not least, some words about sorbent therapy. We can use cytosorb for therapy for patients with cytokine storm, and cytosorb therapy is generally designed to eliminate elevated levels of cytokines and other inflammatory mediators from the blood, and many medical societies incorporated cytosorb therapy into the normal treatment. We have been using cytosorb therapy in 2 patients, but without COVID infection. In the literature, you can find many papers which describe this potential use of cytosorb therapy in patients with COVID-19 infection. In our center, we have been using Oxyrus system of Baxter in 2 patients with COVID-19 with relatively good results. And there are also some data from the literature showing positive results of this kind of the treatment. So, in the summary, I would like to say once again that patients with end-stage kidney diseases are particularly vulnerable to severe COVID-19. Patients with end-stage kidney disease may have higher risk mortality. Clinicians should follow local institutional guidelines to care for end-stage renal disease patients. Patients with COVID-19 should be co-localized on the floor of intensive care unit. Patients should be dialyzed in their own isolation room if it's possible. Telemedicine interfaces with cameras should be used to troubleshoot alarms if these systems are available, but there are no rigorous studies to guide the use of erythropoiesis-stimulating agents for management of anemia in those patients, and vaccinations against COVID-19 should be encouraged among dialysis patients. And with that, I would like to thank you very much for your attention. Thank you very much once again.
Thank you, Prof.
Okay,
that recording was great.
Just a second.
Just one. Sorry.
I can hear you. Just a moment. Oh, now I see. Okay.
Okay, not a problem. All righty. So I just spoke to Eben, who is in charge of the BaxTalks, and unfortunately, although the recording was great, we do need you to do it again with just your face, because they're going to put your presentation on overlays. So it's going to be completely different. So we've got your recording with the presentation, which is great for us for reference. But we need to then also do it just with your face, please.
Yes. So what should I do right now?
If you can you can keep the presentation for your reference on your screen, but we're not going to show it. We're just going to do the presentation again, just with your face, please.
Okay. So, okay. Just a second.
No problem.
Okay, because now I can see you. I see only my presentation, but I don't share the screen. Okay.
Yeah, that's perfect. Thank you. So I'm going to just put us all backstage again, and then we're going to make you. Yeah, if you want to take a few minutes.
No, we can go. We can go right now. No problem.
Alrighty, great stuff. Thank you. So, and in 5.
Good morning. My name is Jacek Zachwieja. I'm a pediatric nephrologist from Poznań, Poland, and I would like to tell you something about chronic renal replacement therapy in pediatric COVID-19 patients. This is my disclosure, and first of all, I would like to greet you from Poznań, Poland. Poznań Medical University is one of the most famous, most important medical universities in Poland, with almost 10,000 students. We perform dialysis in Poznań, Poland from 1958, and we observe continuous development of different methods. And this is like our dialysis department looks nowadays. Some words about COVID-19 in children in general. It will be a short introduction for my main topic. As we all know, we have now almost 250 million of confirmed cases of COVID-19, with more than 5 million total deaths. This high number of infection is related to easy transmission of that virus, because person-to-person spread is the main mode of SARS-CoV-2 transmission. However, an infection may also occur if a person's hands are contaminated by secretion or by touching contaminated surfaces, and they by touching eye, nose, or mouth. SARS-CoV-2 infection can be also transmitted over longer distances through the airborne route, and COVID-19 virus can be also detected in non-respiratory specimens, including stool, blood, ocular secretion, and semen, but the role of these sites of transmission is unclear. From our point of view, from our dialysis perspective, blood transmission appears to be low. We have close contact with the blood all the time, but this risk of transmission is relatively low. Some words about potential vertical transmission, because we are pediatrician and we can observe infection in small babies. However, the extent of vertical transmission remains still unclear. There are only few well-documented cases of vertical transmission or probable vertical transmission, which are responsible for 2% of maternal infection. And in general, pregnancy does not appear to increase susceptibility to acquiring SARS-CoV-2 infection. How about newborn outcome? As it is shown in different meta-analyses, over 95% of newborns positive mothers are in good condition at birth. Most of these patients are asymptomatic. Some newborns of infected mothers have developed symptoms of mild infection only, and neonatal morbidity is related mainly to preterm birth and to adverse uterine environments resulting from critical maternal COVID-19 status. As we all know, not only pulmonary system is involved in COVID-19 infection, we may have also different symptoms and signs related to heart involvement, to kidney involvement, which is the topic of my presentation. But in many patients, we may have also symptoms related to abnormal liver function. Sometimes these patients present symptoms related to gastrointestinal tract, to central nervous system involvement. So many different systems can suffer, let's say, from this disease. How about kidney involvement? If kidneys are involved in COVID-19 patient, it can, let's say, present as a mild proteinuria, mild erythrocyturia. Sometimes tubular CAS can be found in the urine. Renal tubular epithelial cell CAS can be present, or even the whole, let's say, Fanconi syndrome can be found in those patients with COVID-19. How about COVID-19 infection in patients with chronic kidney disease? This is a special situation because these patients, I mean patients with chronic kidney disease, may have comorbidity, they may suffer from diabetes, hypertension, they are dialyzed in center dialysis centers, so it will increase, or it can increase at least, the risk of infection. So first of all, we have to protect ourselves. I mean doctors and nurses, we have to use personal protective equipment, which consists of gloves, of course. We use face masks. We use face shields, because as we know, personal glasses and contact lenses are not considered adequate protection, and we use isolation gown. So the basic principle of our team is to protect ourselves. To help other patients, you have to help yourself first. So protection of the team is a very important issue. There are some important, let's say, policies which are implemented at our hospital to decrease the rate of infection. First of all, we have implemented policies that permit ill-health personnel to stay home. It's obvious, but it must be clear for our nurses and for our doctors. We have identified patients, and we have to identify patients with signs and symptoms of respiratory infection, e.g. fever, cough, before they enter the dialysis department. We have to instruct our patient to call ahead to report fever or respiratory symptoms, so the dialysis center is prepared for their arrival, or triage them to more appropriate setting, for example, acute care hospital. Patients should inform staff of fever and respiratory symptoms immediately upon arrival. And they should carry, of course, a face mask all the time. And we had to provide our patients with instructions regarding hand hygiene, respiratory hygiene, cough etiquette, and the use of face covering, of course. At the moment, for example, we have two children who are treated with dialysis and who are infected with COVID-19 infection. There are some special issues regarding COVID-19 infection in chronic renal replacement therapy patients. First issue is related to atrophysis stimulating agents. As we all know, COVID-19 infection may increase the risk of thrombosis. That's why we decreased the, let's say, target hemoglobin concentration to 10 gram per deciliter to decrease the risk of thrombosis. So we decreased the dose of atrophysis stimulating agent during last month, and we advocate vaccination in our patients. All our adolescent patients are already vaccinated. We are waiting for vaccination, which will be available for smaller children, of course. Some words about acute kidney injury and COVID-19 infection. In one of the, let's say, a very big meta-analysis of approximately 13,000 hospitals patients, the incidence of acute kidney injury was described as 17%, although the range of AKI incidence was very broad, ranging from 0.5 to even to 80%. And in adult, let's say, population, approximately 5% require kidney replacement therapy. In pediatric population, this number is lower, between 1 or 2% only. The incidence seems to vary by geographic location, and proportion of critically ill patients should included in each study. And last data suggest that the rate of acute kidney injury is declining over duration of the pandemic. How about pathogenesis of acute kidney injury of COVID-19 patients? As you see, there are many direct effects of virus and indirect effects of the infection. Very important issue is the degree and the presence, at least, of dehydration. Dehydration can be secondary to decreased fluid intake, can be related to vomiting and diarrhea, and overuse of diuretics to keep lungs dry, because our anesthesiologists should like to have lungs dry, and they overuse diuretics sometimes, which may lead to acute kidney injury. Of course, cytokine storm, which is related to high interleukin-6 concentration, but not only. There are many other cytokines which are involved in cytokine storm, and acute kidney injury can occur due to renal inflammation, to increased vascular permeability, third space fluid loss, intra-abdominal hypertension, and hypovolemia. The next problem is interaction between different organs. For example, aggressive ventilation and hemodynamic instability are associated with altered kidney function as a component of so-called organ crosstalk. And of course, we observe local effects of the virus, because SARS-CoV-2 virus may directly attack proximal tubules, but not only proximal tubules. And of course, use of different nephrotoxic drugs, including antiviral drugs, may also lead to acute kidney injury. Within kidneys, we observe high number of AC2 receptors and high number of TMPRS receptors. And because of those receptors, we can find viruses not only within lungs, but we can find virus within glomeruli and within tubules. Not every patient have positive kidney for SARS-CoV-2, but those patients who have positive kidneys for SARS-CoV-2 have higher risk of acute kidney injury development. And those patients with positive kidneys for SARS-CoV-2 have also a lower probability of survival. From histopathological point of view, the typical, let's say, finding is renal tubular necrosis, acute tubular necrosis, but we can also find collapsing focal segmental glomerulosclerosis, and sometimes we can find thrombi within kidneys. And depending on the degree of renal tubular necrosis, we can observe different, let's say, stages of acute kidney injury. And last but not least is renal replacement therapy in pediatric patients. There is a general rule that the indications for renal replacement therapy for acute kidney injury remain exactly the same regardless of the COVID-19 status of any given patient. There are some practical issues which should be discussed and to be implemented in your everyday practice, let's say. If it's possible, patients with COVID-19 acute kidney injury who require renal replacement therapy should be localized on a floor with intensive care unit. And in our center, we have our dialysis department closely, let's say, related and closely localized to the intensive care unit. The second issue is related to nurse care. And if a patient is in a negative pressure isolation room, then one hemodialysis nurse will need to be dedicated only to that patient in 1-to-1 nurse-to-patient ratio. Patients with suspected or confirmed COVID-19 who are not critically ill, but who have acute kidney injury requiring renal replacement therapy should be dialyzed in the isolation room rather than being transported to the inpatient dialysis unit. And in our patient department, in our patients, we prefer continuous renal replacement therapy if it's possible. It's also the preferred method to children. If we are talking about CRT machines, they can be either placed inside an isolation room or outside the isolation room using extended tubing. And the placing of the machine outside the room minimizes the need of repeated entry to troubleshoot and manage the machine, and therefore reduces wastage of personal protective equipment. However, this extended tubing is a scarce resource, and the use of extended tubings requires additional tubing connections and increases the likelihood of the tubings will be disconnected. In pediatric patients, it's important that these extended tubings also increase the volume outside the patient body, and this additional volume is also important in pediatric patients. Extended tubing also decreases the sensitivity to pressure alarms to detect disconnection of the venous lines and potentially increases the risk of clotting due to longer tubing length. And what is very important, if the needs of renal replacement therapy are, let's say, high and the renal replacement therapy capacity at the hospital is overwhelmed, these continuous renal replacement therapy machines can be used to deliver prolonged intermittent treatments. For example, in those situations, we can perform 10-hour dialysis rather than continuous, with higher flow rates, of course, to deliver the proper dose of the dialysis. Very important issue is potential risk of thrombosis during renal replacement therapy, because it may occur more common in patients with COVID-19, as we all know. And of course, if there is no contraindications, all patients should receive anticoagulation during continuous renal replacement therapy. And in our center, we prefer low molecular weight heparin, but we can also use unfractionated heparin. What is very important, we are using higher doses of the heparin in patients who are infected with COVID-19. Regional site renal anticoagulation appears to be less effective among those patients, and that's why we prefer heparin at the moment. How about timing of renal replacement therapy initiation according to KDIGO guidelines. The timing of renal replacement therapy, vascular access, and modality of renal replacement therapy should be based on patient needs, local expertise, and the availability of staff and equipment. Some words about peritoneal dialysis. We have patients on peritoneal dialysis who were infected with COVID-19 infection. And we have to remember that it is a relatively safe procedure. And those patients have similar rates of all-cause mortality, kidney function recovery, and infections complications compared with patients treated with other modalities. Peritoneal dialysis can, of course, increase intra-abdominal pressure, and theoretically it may interfere with respiratory mechanics, but in, let's say, our practice, it can be performed very easily, even in mechanically ventilated patients. If it's possible, we prefer automated peritoneal dialysis, and in our center, all these patients who were infected were treated with cyclers. And what is important to remember, data suggesting that peritoneal dialysis effluent is infectious are lacking, so it is a relatively safe procedure. There are also different reports about sorbent therapy in COVID-19 patients. For example, there are some reports showing cytosorb therapy, because this kind of therapy is designed to eliminate elevated levels of cytokines and other inflammatory mediators from the blood, as is intended to serve as an adjunctive therapy in systemic hyperinflammation by modulating the cytokine storm. So there are several national medical societies incorporated cytosorb into the treatment of COVID-19 patients, and there are some data and there are some papers which shows positive results after cytosorb therapy in COVID-19 patients. In our center, we have been using Oxyrus, which is a system of Baxter, in 2 patients with COVID-19 with good results. And such data are also available in the literature, showing that this type of treatment can be helpful in some group of patients. So in the summary, I would like to say it once again that patients with end-stage kidney disease are particularly vulnerable to severe COVID-19. Patients with end-stage kidney disease may have higher risk mortality. Clinicians and nurses should follow local institutional guidelines to care for end-stage renal patients. Patients with COVID-19 should be co-localized on the floor with intensive care unit. Patients can be dialyzed, if it's possible, in their own isolation room. Different methods like telemedicine interfaces with cameras can be implemented to troubleshoot alarms. There are no rigorous studies to guide the use of erythropoiesis-stimulating agent for management of anemia, but as I mentioned, we have decreased the dose of those agents in those patients, and vaccination against COVID-19 should be encouraged among dialysis patients. And with this, I would like to thank you for your attention. Thank you very much.
That was great.
Okay, thank you. Just a second, I can hear you. Oh, yes, now I see you. Okay.
Awesome. Thank you. That was wonderful. Thank you so much for doing that again. You really did. You nailed it. So thank you so much. Anything
Okay,
from you,
okay.
sir?
I know that you will prepare the final version. You can just cut out some information, because I don't know what was the general, idea of this BaxTalk, and what was the topic of our other, let's say, presenters. So I hope you will do it well, let's say.
We will. Thank you so much. And then your presentation, will you send it through to us, please? I'll drop my email address in the private chat here, so that we can just use that, please.
Okay, to this production digital tech.
Digital
Okay,
access the tech, yes, please.
okay, I'll do it right now.
Wonderful. Thank you so much, Prof. Thank you for your
Okay,
time.
thank you
And
very
sorry
much.
to keep you waiting, but thank you. I appreciate it. All
No
righty.
problem.
Dziękuję, panie profesorze. Thank you.
Do widzenia,
Thank you.
thank you very
Do widzenia.
much.
Bye. Thank you.
Bye-bye.